Hi, good afternoon, everyone. Can everybody hear me? Okay. So I've been tasked with keeping us on schedule, but welcome everybody to one of the kind of afternoon sessions where we'll kind of go into a little bit more detail on the cardiovascular implications and manifestations of Turner syndrome. I'm sure you there was a number of people out in the audience who heard me talk this morning. A little bit of what I'm going to go over is going to be a review of what I talked about this morning, but I'll try to go into a little bit more detail on some of the complications in the pediatric world specifically, and Dr. Prakash, who will join us in just a few minutes, will be going over the adult world of cardiovascular disease in Turner syndrome. But in addition to sort of some recycled information from this morning, I'll be trying to go into a little bit more detail about some of the things that we spend a lot of time talking about in clinics and get a lot of questions about too. And then there'll be time afterwards for questions as well in a Q&A session. So without any more delay, we'll go ahead and get started. So I obviously don't need to define Turner syndrome for you. I think that's been done 10, 20 times already before today. But the reason why I'm standing up in front of you is because there's a lot of really distinctive cardiovascular manifestations of Turner syndrome that we see and take care of on a daily basis. And so we'll be going through those in particular. And so I think whenever we start talking about heart disease, it's really important to start out with what is normal so we can sort of understand the things that we see that are abnormal that need to be taken care of and treated. And so I'll kind of walk you through normal cardiac anatomy first, and then hopefully that'll serve as a way to understand sort of the next things that I'll go through. And I wish I had a pointer. I don't. So you're going to have to bear with me describing this diagram over here. But this is a normal heart, a kind of cartoon you see on the left side. And the heart has 4 chambers. There are 2 top chambers called the atria, and those are sort of the storage chambers of the heart. And there are 2 bottom chambers called the ventricles, the RV and the LV up here, and those are the pumping chambers of the heart. And as we kind of follow the way the blood flows through the heart, blood comes back from the top half and the bottom half of the body, and it's sort of depicted in blue here, the used blood that comes back. It comes back to the right side of the heart and gets pumped by the right side of the heart to the lungs. And in the lungs, we know that oxygen gets into the blood, and so really fresh, richly oxygenated blood comes back to the left side of the heart, and you can kind of see in the pulmonary veins, we'll talk about those in a minute. It comes back to the left side of the heart, depicted in red, and then gets pumped through the aorta, which is the biggest blood vessel in the body, out to the body. And you can see on the left, there's sort of a cartoon also of the aorta. And one thing to really pay attention to is the shape of the aorta. It sort of has this nice, evenly distributed, smooth candy cane shape. And that's something that's we'll talk about a little bit more detail as we go along. So just as like we had talked about earlier, there are really 2 types of heart disease kind of buckets that we like talking about in Turner syndrome. The first is congenital heart disease, and that's heart disease that one is born with. And the second one is acquired heart disease that develops later in life and that we oftentimes have to screen for. And so the incidence of congenital heart disease that you're born with, is in up to 50% of those with Turner syndrome. And there's a number of different very common lesions that we'll talk about that we find, but they range from an abnormally formed aortic valve to narrowing of the aorta to abnormalities in the veins, whether it's the pulmonary veins, the veins that bring red blood back to the left side of the heart, or even the major veins that bring blue blood back to the heart. And we also know that a lot of these major defects and common defects in heart and blood vessel development result in or are major contributors to the high mortality rate for fetuses that we see in Turner syndrome. So the first thing we'll talk about is one of the most common things that we see in Turner syndrome. And if you were talking to a med student and they had just learned about Turner syndrome, this is probably one of the few things that they'd actually be able to tell you. and that would be a bicuspid aortic valve or an abnormally formed aortic valve. So a bicuspid aortic valve is actually a pretty common finding. It's found in about 2% of the population, in the general population, but much more common in Turner syndrome. Up to 30% of those with Turner syndrome will have bicuspid aortic valve. Now, you can kind of see on the right, there's a cartoon of the heart, and the aortic valve is sort of like the door that opens up and allows blood to go from the left side of the heart, that left-sided pumping chamber, to the rest of the body. And valves in the heart keep blood going forward. They're sort of like doors. They open, keep blood going forward, and then they close and prevent blood from going backwards and protect the heart from getting overloaded with fluid kind of going backwards. And a normal aortic valve is tricuspid, meaning there's sort of 3 doors that open and close, whereas a bicuspid aortic valve that you can see farther on the right is bicuspid, has 2 cusps or 2 doors that open and close. So there can be a number of complications associated with a bicuspid aortic valve. Sometimes those doors don't open quite properly, and so can restrict flow across the valve. The doors don't open quite wide enough, or sometimes those doors don't close quite well enough and cause leakiness. And whether it's not opening properly or not closing properly, oftentimes those can be things that we can listen to on with a stethoscope. The doctor puts their stethoscope on your chest and they hear a murmur. Those are some of the features that they can hear, that leakiness or that restricted flow across it. However, more often than not, the bicuspid valves, especially in childhood, can be silent. Not only can we not hear them, but oftentimes there's no functional consequence to them early in life. So from a pediatric cardiology perspective, oftentimes bicuspid aortic valve doesn't require any intervention in childhood, but regardless of whether or not there's a little bit of leakiness, a little bit of restriction, or nothing at all, this is something that requires lifelong follow-up and surveillance. Because even if your bicuspid aortic valve is working beautifully when you're 5, there's a high risk for, as adults get older and older, and we know this just from the general population too, into your 50s, 60s, and 70s, that those bicuspid valves tend to harden at sort of an abnormal rate and tend to get more restrictive with time than normal tricuspid valves. And we'll also talk a little bit later about how these bicuspid aortic valves are also a risk factor themselves for aortic dilation or aortic tears. And so it's something that sort of plays in our mind for risk management going forward. So the next thing we'll talk about is a coarctation of the aorta. Now, I know that this is sometimes confusing, talking about how the aorta is narrow. No, the aorta is wide. No, the aorta is narrow. No, the aorta is wide. Well, this is a narrowing of the aorta, and something we really have to worry about both things in Turner syndrome. It's a narrowing of the aorta as it courses down near the spine. This is something that is generally present early in life and not something that really develops after the time you're 1 or 2 years old. And it affects a good proportion of those with Turner syndrome, 7 to 18%. Now, when diagnosed really young in life, oftentimes it is severe. The heart can't pump blood across that teeny tiny space, and so anything past that narrowing has trouble getting blood to it. And that can include all the abdominal organs like the liver, the spleen, the kidneys, the legs. And so oftentimes it requires an intervention to repair. It usually requires an intervention to repair. In the first year of life, that usually means a surgery to cut out that narrowed area. But as we get older, or if there are cases where it's not quite as severe and maybe doesn't get caught until later in life, there are other options that don't require an open surgery, like a catheterization, where we use balloons inside the vessel to blow it up and have a stent placed to keep it open that can be used instead of a surgery. So this is sort of a long technical phrase, partial anomalous pulmonary venous return, or PAPVR. This happens when one or more of the 4 veins that drain red blood from the lungs back to the top chamber of the left side of the heart drains instead of to the left side, it drains to the right side. This is very common in Turner syndrome. It affects about 15% of patients that we see. And as you can see on the left-hand side, that normal heart has all of those red veins coming back to the LA, or the left atrium, that left top chamber, and there's no mixing of red blood and blue blood. In PA-PVR, instead of all of those veins coming back from the lungs and bringing back that fresh red blood, you can see there's one that actually drains to the wrong side. And so because of that, you have red blood draining back to where only blue blood should be. Red and blue make purple here. And so that can be a problem when there's too much blood that's going to the wrong place. Now, fortunately, this is usually something that doesn't require surgery. When just one vein is going to the wrong place, oftentimes it's going to be something that we can just monitor with time. But it can require surgery when there are other things going on, or when it's one or when it's more than one vessel, or when we see consequences to that extra flow going to the wrong place. And just kind of like we were talking about with PA-PVR, there can be other venous anomalies as well. So a bilateral superior vena cava is when, instead of having one superior vena cava, or SVC, you can have two. Now, what is an SVC, or a superior vena cava? It is, in most individuals, we all have one. It's on our right side, and it drains the used blood from the whole top of half of your body back to your heart. And instead of having that one large vein that drains blood back from the top half of your body to your heart, you have two, one on the right and one on the left. This affects about 15% of patients with Turner syndrome, but usually, luckily, never requires surgery. Oftentimes, this is sort of just one of those things that, it's an interesting thing to know. Do we ever have to image this again? If this is the only thing we see, this is not something that we have to follow up on. If I were to see someone in clinic who just had a bilateral SVC, I'd say, hey, write this down in your notebook. I never have to see you again. And so it's not something that we generally have to do anything about. So, earlier in the day, y'all got a number of really nice talks talking about congenital heart defects in Turner syndrome in terms of the surgical outcomes that we see. It's a very common question that we get asked. Hey, my daughter has Turner syndrome, is going in for repair of a defect. How is she going to do compared to others who have that same defect? So the good news is that in general, the long-term outcomes, years later, decades later, there really doesn't seem to be any difference that we've seen. That girls with Turner syndrome, after surviving a heart surgery, do just as well in the long run with regard to sort of their cardiovascular health related to that surgery as those who don't. There tends to be a rockier course along the way, though, and it has been shown that those with Turner syndrome can have longer lengths of stays for a number of various reasons, whether it's lymphatic abnormalities, holding on to extra fluid, needing a couple extra days in the ICU or the hospital. But again, even though there's a rocky road to getting out of the hospital, once you're out of the hospital, our long-term outcomes are quite good after a major cardiac surgery in childhood. The one exception to that rule is in something called hypoplastic left heart syndrome, which is something that some people may read about and see. It is on the most severe and critical end of the congenital heart disease spectrum. It's not something that you will find out about when you're 2 or 3 that you have. These are children that are born that are critically ill 12 to 24 hours after birth. It is a really very, very difficult disease to manage, even in those without an associated genetic condition. But we have found that in those with Turner syndrome and hypoplastic left heart syndrome, that the outcomes are poor, and poor compared to those who don't have it. And there are still efforts to figure out exactly why that is, but that was sort of the one exception to the rule. Now, we talked a little bit earlier today about electrocardiogram abnormalities, and that there are really a variety of benign electrocardiogram abnormalities that we see in those with Turner syndrome. Some of those can be like a slightly higher resting heart rate, and we think that this is because there are changes in the autonomic nervous system in those with Turner syndrome. So what is the autonomic nervous system? I like to think of it as it's like the automatic nervous system. It's things that regulate how fast you breathe, how fast your heart beats in the background. when I'm given a microphone and asked to talk in front of a bunch of people, my heart rate goes up by 10, 20 points, right? When I'm walking and if I'm on a hike and I see a bear, what happens? My heart rate goes up. Those aren't things that I consciously control. Those are part of my automatic or autonomic nervous system. And there's something about that nervous system that is slightly dysregulated in those with Turner syndrome that we think contributes to the perhaps blood pressures and certainly to a slightly higher resting heart rate and perhaps some of these electrocardiogram findings as well. One thing that we do get a number of questions on, because it is common, is a prolonged QT interval. So when we get an electrocardiogram, again, electrocardiogram is a measure of the electrical activity or the conduction system in the heart. We put electrodes on the chest and we kind of look to see how the heart rate looks. We get a number of sort of bumps and humps, some waves that we look at, and as cardiologists, we're pretty simple people. We name things using the alphabet. So this is a P wave, this is a Q wave, this is a T wave. And so the QT interval is just the amount of time between the Q wave and the T wave in an electrocardiogram. It's the amount of time between when the heart ventricles, the kind of those big pumping chambers, the electrical activity that causes them to beat, and then the amount of time it takes them to relax in order for them to be able to beat again. So in the general population, those with a prolonged QT interval can be at risk for abnormal heart rhythms and even sudden cardiac death. But this, and again, I want to emphasize this, that link has not been shown in those with Turner syndrome. Why do those with Turner syndrome have a prolonged QT interval? We don't have a great explanation for that. Could it be something to do with the automatic or autonomic nervous system? Could it be something to do with the genetics associated with the way that our ion channels work in the heart? I don't have a good answer for you, but certainly because it's something we don't have a perfect answer for, it's something that we screen for and make sure that we're not going to miss. And so what do we do in individuals if that QT is prolonged? Just like I had talked about earlier today, there are things that we can do to sort of risk stratify. Are these, this QT prolongation something you need to worry about, or is this something that we can just kind of follow with time and not have to do anything about for the time being? And so two things we can do to risk stratify are, one, do a Holter monitor. And a Holter monitor is essentially an electrocardiogram that instead of giving you 10 seconds of information, it gives you 24 hours of information. It allows you to see if there are any abnormal heart rhythms or heart beats in the background that could tip you off to something that perhaps we need to take this QT interval more seriously. And another thing we can do is do an exercise stress test. And what's been shown in individuals with long QT, or long QT syndrome is something that's totally different, and that's really the thing that we worry about when we see a long QT in the general population. When we exercise them, that QTC, or that QT interval, stays prolonged. Whereas in the more benign forms, and very often in those with Turner syndrome, when we exercise them and your heart rate goes up, that QT interval normalizes or gets shorter. And so whenever we have a patient with Turner syndrome who has a prolonged QT interval, those are two things that we'll do, in addition to recommending that there are a lot of different medications out there that can cause the QT interval to be prolonged. And we usually will give a packet of information or a website that on medications to avoid when possible. A question we get asked a lot of times is, oh, hey, should I completely avoid this medication? Another doctor really wants to prescribe this, or I have something that, that's my only option. These, very rarely do we say that those medications are completely contraindicated, but it's oftentimes the case that when we start them, we just have to make sure that we get another repeat or ECG maybe a couple weeks later to ensure that we're not making that QT interval worse, or that we're not unearthing something that we would be worried about. Okay, and so we'll talk a little bit about aortic dilation and dissection too. I know Dr. Prakash will probably go into a little bit more information than me because he's an adult cardiologist. But aortic dilation is when we have an abnormal widening of the aorta or an enlargement of the aorta. And I've got a couple pictures down here. Again, on the left, you'll see that really nice, normal, smooth candy can shape. There's no obstruction. And the ascending aorta, which is kind of going up, It's the hook on that candy cane, and the descending aorta, which is going all the way down to the rest of the body, all look to be kind of about the same size. And in those with aortic dilation, as you can see sort of from a cartoon, first on the right and then from an MRI picture, the ascending aorta, most characteristically, is the one that becomes bulbous and gets much bigger than we would expect. Now, an aortic dilation can occur at any age and is something that we do commonly see in younger girls, and generally speaking does not really cause any symptoms at all. And so it usually is something that's silent, that's going on in the background, and it really can only be identified and monitored by echocardiograms, CT scans, or MRIs. Whereas an aortic dissection, which again, I won't go into a whole lot of detail on because it's an extraordinarily rare event in children, but an aortic dissection is when the aorta actually tears. And one of the things that we care about as pediatric cardiologists is the aortic dilation. If the aorta is enlarged, we believe that that predisposes individuals or makes them at higher risk for potentially having an aortic dissection. You heard in some of the talks earlier of those that underwent repair of dissections, all the aortas were much larger than we would expect for someone's age and size. So there are a couple of other features that put someone at higher risk for an aortic dissection. You know, when we looked at, and when researchers looked at sort of big populations of those who had dissections, they looked back to see, are there any common features that are more common in those that dissect than those that don't? More common in those that have ruptures of the aorta or those that don't. And they found that those with bicuspid aortic valves, a history of coarctation of the aorta, even if it's repaired, and high blood pressure were more common than otherwise. And pregnancy was another thing that I think Dr. Prakash will go in a little bit more detail into. And so, you know, why do we care about these things? Because these risk factors inform how often we recommend to get screening done. So again, this is something kind of I went over a little bit earlier in the day, so I'll try to focus on clarifying a few things. You can see from the left-hand branching pattern, that's sort of the lower risk pathway with no high risk categories like coarctation, bicuspid aortic valve, or hypertension, high blood pressure. And the right side is the higher risk pathways. The next thing that tells us is someone at a higher risk for an aortic dissection compared to others is how big the aorta is. So this can be a little bit confusing, I know, even for physicians. There are a couple ways that we measure, a couple of things we measure to look to see is someone's aorta dilated or not. The first is going to be the absolute measurement of the aorta. I have a 5-year-old girl that comes in, we do an echocardiogram, and I measure her aorta to be 2 centimeters. What does that absolute number mean? Sometimes that's hard to tell. And so the reason why we use z-scores is because unlike adults where we have really nice comparative data, memorizing what's normal for a child who is 8 or a child who's 5 can be very difficult, especially when we're at different kind of developmental spectrums too. And so what a z-score does is it indexes the absolute measurement that we take. It takes it 2 centimeters and it tells me how different is that from what I would expect from a girl who is a certain size, a certain height, a certain weight. And so a z-score of 0 is someone who has an absolutely stone cold average aorta for their size and their height and their weight. Lower z-scores mean you're smaller than we would expect, and larger z-scores mean you're higher than we would expect. And so a z-score of 3 is very enlarged compared to what we'd expect and sort of what we see based on what's sort of quote-unquote average. And to give you an idea for sort of where that ends up in the spectrum of high risk versus low risk, a z-score of, if you were to have a Turner syndrome specific z-score of over 3, that would mean that if I were to line up exactly 100 girls with Turner syndrome who had your exact same weight and your exact same height, and you had a z-score of over 3, that means that you would be the 99th or the 100th largest aorta amongst them. And so I think that that's a good way to sort of think about how the risk stratification, that would be on the much higher end of the spectrum compared to those with Z-scores that are lower. And so sort of back to this figure, those without risk factors and who don't have significantly enlarged aortas, we recommend that imaging every 5 years can be reasonable, although there are some practitioners that may, while kids are going through puberty and are going through periods of heightened growth, that they may choose to image slightly more often than that, and that can still be a correct decision based on a lot of other individual factors. Whereas those without any risk factors, but with an enlarged aorta, we recommend yearly imaging. Whereas those who do have those risk factors, even if your Z-score is under 3, then we recommend imaging every 1 to 2 years because there are other risk factors present. And in those with enlarged aortas and in the high-risk category, we recommend imaging at least once yearly, if not once every 6 months. Another thing that I know Dr. Prakash may touch on is that these Z-scores we really only use up to the age of 15. And so why do we transition to something different afterwards? Well, one, most girls are done growing at the age of 15, so we can sort of think about them more in the adult world. And so after the age of 15, we use something called an ASI, or an aortic size index. And really similar to Z-scores, they really just give us a sort of a normative value based on someone's height and weight that allow us to be able to sort of compare apples to apples instead of apples to oranges. And so if you are thinking about where you are on that spectrum, that can be a really helpful thing. And the one last thing and sort of caveat that we oftentimes have to talk in clinic about is that Z-scores and ASIs are still not perfect tools. Especially Z-scores can be dramatically affected by whether or not someone weighs a lot more or a lot less than we would expect for their height. So in someone who weighs a lot less than we would expect, or someone who weighs a lot more than they would expect, that may dramatically change the Z-score enough that we as physicians have to think, okay, yes, your Z-score is 0 or your Z-score is 4, but that may be partially affected by your weight, whether it's high or low. And so because it can complicate the picture, we always want to make sure that we're kind of taking all of our numbers into effect. And then finally, the last thing that I'll talk about before Dr. Prakash takes over is activity guidelines in sports. And so why do we spend so much time risk stratifying folks? And it's because we want to make sure that we're doing the best to ensure that you can live the healthiest lifestyle that you can. And the reason why I emphasize so much how far on the end of the spectrum a Z-score of 3 is because it goes to show how many people we can capture and allow them to participate in activities and participate in competitive sports when you think about everybody beneath that 99th or 98th biggest aorta. And so in those with normal aortic size, we think that it's reasonable to be able to participate in all sports. And those who have mild to moderately dilated aortas, participation even in low and moderate intensity sports can be advised. And that, again, can include a lot of really great options in terms of sports. The things that we recommend against are things that will dramatically increase the blood pressure when you're performing them. So that would be things like really, really intense weightlifting. You almost can kind of think about the aorta. It's like one of those long balloons that kind of will be blown up at a kid's party. The more pressure you put into the inside of it, the more likely it is that it's going to be to enlarge. Now, luckily, our aortas are not nearly as distensible as a balloon party, but chronically over time, that exposure to higher pressures within the aorta is thought to be a risk factor for it getting enlarged over time. Another question we get asked a lot is, okay, well, I looked, Dr. Jones, I looked this up online. When you go running, one of the natural responses to running or to exercising, any type of exercise, is that your blood pressure gets a little bit higher. But when we think about exercise in general, people who exercise regularly have lower blood pressures and lower heart rates than those that don't. And so even if your blood pressure is transiently higher when you're going for a run for 40 minutes a day, If your blood pressure for the other 23 hours a day is lower and your heart rate's lower, oftentimes the medications that we'll use to prescribe do exactly that. So I think it's really important to emphasize the enormous benefit that exercise can play, and not just in our cardiovascular health, but in the kind of the health, the rounded health of all those with Turner syndrome and otherwise. And then finally, those with moderate to severely dilated aortas, we advise not to participate in sports. But regardless, these are all decisions that are made with families and with the practitioners and those that serve y'all. And so there's lots of other factors like the aortic valve, congenital heart disease, elevated blood pressures, and just tolerance of risk, comfort with the decisions that get made that don't always fit perfectly within the guidelines. And so whenever there's a question about this, I think it's so important to talk to your cardiologist, talk to your team, and talk to whether it's your parents, your families, your children, about sort of what the things that you value the most are, because really I think that exercise and leading a healthy lifestyle are really paramount to managing risk later on in life, which I'm sure Dr. Prakash will talk about in a minute. So thank you so much for your time. We'll be taking questions later. And again, really, really honored to be able to kind of talk with you all about this, and looking forward to any questions you may have.
All right. We are going to be taking questions and answers at 4 p.m. in the Tanglewood room, I believe, unless that changed. So hello, everyone. I'm Dr. Prakash. I talked to you earlier about a few guidelines things and some research. I prepared a short talk that goes, you'll hear a lot of things that you heard before, but that's good. We want to repeat things that are really important, and hopefully these are the highlights. Of course, if you have any more specific questions or individual questions, we can address those at the Q&A. So I run the adult Turner Syndrome Clinic at UT Health Houston. We have a pediatric clinic, and I transition patients. So I see patients anywhere from age 17 and older, and many times I'm seeing them with their parents, for the first 2, 5, 10 years sometimes. And I specialize in teaching people how to take care of your own aortic disease, like to know what it is you need to know and how to advocate for yourself. And that's really important with aortic disease in particular. So you've heard before that aortic dilation, another word for that is aneurysm. And some people ask me the difference between those two. It's a difference of degree. So dilation is any enlargement more than we expect. An aneurysm has to be significantly more than we expect. And we have a cutoff for that. But the bottom line is if someone tells you you have an aneurysm, it's a big dilation. So it can develop in adulthood after being normal in childhood. This is many times we hear confusion. So if someone has had a normal Z-score or aortic measurement, they're often told by their pediatric cardiologist, yeah, you're normal, and they can interpret that as, I'm good to go. I don't need to see a cardiologist because there's nothing wrong with me. In Turner syndrome, this could not be farther from the case. We know many examples of people who developed aneurysms in adulthood, and these can be clinically significant, typically between the ages of 20 and 35 years, but they can even develop later in life if you've had previous cardiac or aortic surgery. So it is something that requires lifelong monitoring. And as we mentioned before, if you're a smaller person, you need to have your aortic size adjusted to your body size. So if someone tells you a number and it's in centimeters, you should politely ask them, so what is my index or what is my Z-score? Those are the two methods we use to adjust for body size, and they're widely available online. You can look them up. Calculators are available. So your adjusted aortic size is actually what determines your risk, not necessarily the absolute size. Particularly if you're small, it's very important for your doctor to do that. And an aneurysm, again, is defined if it's about 1.5 times larger than would be expected for someone your age and size. Most people with Turner syndrome who have aneurysms have at least one other heart problem, like bicuspid aortic valve, but not everyone. And these are the flavors of the aneurysms that we see in Turner syndrome. They affect usually 2 aortic segments. So in knowing your aorta, you should know that in the chest there are four main parts of the aorta. There's the aortic root, and that's the real close to the heart part where the valve sits and where the coronary arteries come off. Then there's the ascending aorta, which is the tube part that goes up towards the top where your head and neck are. And around at the base of the neck, it makes a U-turn and it goes down to your legs. That's called the arch. And then the rest of your chest, the aorta going down in your chest, is called the descending thoracic aorta. Some people abbreviate that DTA, but that's what it means. So those are the four parts, and it kind of looks like a candy cane in a normal person. Your aorta probably doesn't look like a candy cane if you have any sort of heart problem you were born with, like bicuspid aortic valve, because that changes the shape of the aorta. But in general, that's where these two parts, the root and ascending, is where the aneurysms are. And the good thing about that in Turner syndrome is that we can take good pictures of those with an echocardiogram. We don't necessarily need a CT or MRI. For those of you who have had a healthy heart echo here, you will know that we focus on those parts for most of the echocardiograms because that's where the largest part is likely to be that we need to measure. So the other factor that I just mentioned is that even if somebody tells you your aortic diameter is quote unquote normal, you need to politely push back and say, what's my index diameter or Z-score? Because that could be high even if the absolute size is normal. Why? Because all the absolute size criteria were developed for normal-sized male individuals who are much bigger on average than a person with Turner syndrome. So that means that all the cutoffs based on size are no good for Turner syndrome. So this is what it looks like on the right here. When we take a picture of your root and ascending aorta, many of you might have been able to see this. Sometimes they let you watch when they're doing the echo, but if you do watch, you'll see that there's the aortic valve that's kind of opening and closing, kind of in the middle of the picture. That's that line going up and down. And then to the right is your aorta, the aortic root first, and then the ascending aorta going up. And those are the two places where we measure the most carefully in Turner syndrome, because in many people, one or both of those is going to be dilated. And then sometimes, if we can't get pictures with an echocardiogram, we do a CT scan or an MRI scan, and then the aorta looks like this. That's a picture of the entire left ventricle and the aortic root and the ascending aorta. And I've kind of put numbers there that correspond to each one, going all the way up to the arch where it turns and goes down to your chest. That gives us the best single view of the aorta. And we often recommend that a person with Turner syndrome gets that done about every 10 years, even if your previous one has been normal, because it lets us see parts of the aorta we can't see on the echo. And that's kind of a better way to monitor things. It gives us better measurements. So points to remember that when you go into your doctor's office, always know your aortic diameters. You can either know the absolute number, or better, you can know your Z-score or indexed size. Know when your next set of images are due, and go to a place that specializes in doing aortic imaging. That's different than a regular cardiologist's office. They're going to make extra measurements. Sometimes that place will advertise themselves as an aortic center or aortic center of excellence, aortic institute. There are lots of names like that. Most large cities have them, and most of them advertise their services. If you can't find one, your cardiologist will know where the nearest one is. It's important to do that at least once, even if you don't get your regular images there, because they're going to give you the best true measurement of your aorta. We've definitely seen a case where people have gone to their local cardiologist for years, gotten their aorta measured, and it was incorrect, right? And it gave them the wrong kind of impression of how their aorta was doing. Sometimes they didn't see all of the aorta, but they would report it as normal, even if they didn't see it. In an aortic center, they will tell you if they don't see it and recommend that you do a CT or MRI scan. So that is one of the major differences. And the other thing to know is that CT scans, especially in young people, give you an unhealthy dose of radiation if you do them year after year. So we do recommend considering MRIs. MRIs are not for everyone. If you have claustrophobia, they can be managed, but it is difficult. Sometimes we have to give you a mild sedative, so we do take that into account. But if you can do that, you avoid the radiation. So this is the other problem that we look at with an echo. It's the bicuspid aortic valve. And as I mentioned, more than 1 in 3 individuals with Turner syndrome have one. The main difference is that instead of looking like a Mercedes-Benz symbol with 3 equal segments, it looks kind of lopsided. And that lopsidedness is actually important because it means that the valve just wears out faster. You can think of it like any other part in a machine. If it's not working symmetrically, it's going to wear out faster. So the wear and tear catches up, and these are things that happen to everyone, but they just affect the bicuspid valve more. What do we mean? So things like high blood pressure, high cholesterol, diabetes, they cause deposits or debris to build up on the valve, and that just makes that valve work less efficiently over time, and you can run into these issues. So over time, the valve can wear out, it can need to be replaced. The heart walls can thicken because now the valve is sticky, it doesn't open well. You can get shorter breath. So it's one of the leading causes of needing heart valve surgery, and it typically takes anywhere from 20 to 40 years for that process to happen from the time that we first diagnose it. So if we know a young person has a valve and we look at the valve, we can generally give you a timeline about when that's going to wear out, when that might start to be a problem. And it's usually not for at least 20 years. But we keep an eye on it because it can get worse over time and it can cause symptoms. And if it does, there are effective treatments available that don't involve open heart surgery with a scar. We can go from the inside in some cases now, so that it's much easier to treat than it used to be. But if you have heart disease related to a bicuspid valve, there are other medications you may also need to be on. And then we talked about coarctation. Most people with bicuspid valve are going to have at least one other heart problem. Sometimes it's easy to see, sometimes not so easy. Coarctation we generally look for because it's relatively common. The main point about coarctation, there are 2 points. First, even if you had your coarctation fixed when you were an infant or a child, it can still cause problems in adulthood. The important thing to know, the most important problem is high blood pressure. It's the major cause of high blood pressure in Turner syndrome. Even if you had the coarctation fixed, it can come back as an adult in the form of unexpected high blood pressure that requires constant medical care. And we see this around age 30 to 35 in people who've had a previous coarct repair as a childhood. They may have been asymptomatic, symptom-free, and normotensive for years, and they suddenly show up with hard-to-control hypertension. It happens. So you do need to keep an eye on that if you have that history, and just kind of be aware that you need to get your blood pressure checked a little more frequently beginning in your late 20s and early 30s. And there are effective treatments for this if it does develop a new coarctation, which can happen in a minority of cases without needing, again, major surgery. So if we do see that the blood pressure is increasing, we'll go check the coarctation. Did it come back? Or is something else happening to cause that blood pressure to go up? There are many different factors in Turner syndrome that can interact to make it worse. So these are the main ways we repair coarctation. There is a patch repair. A lot of people get the end-to-end repair. The important thing about this is that whenever you do surgery on an aorta, it's never the same. And we have had several cases in which the site of the former coarctation repair, between 30 and 50 years after the repair, develops an aneurysm in Turner syndrome. It's something that we watch carefully, and so we recommend doing regular CT or MRIs of your chest if you've had a coarctation repair to check that site, because it can develop relatively quickly for reasons that we don't understand. Possibly it's related to hypertension, but it can be unpredictable. And it's easy to detect with a CT or MRI scan. Again, the echocardiogram is not going to see that well enough to be definitive, so we really need that additional imaging. Okay, and of course, I mentioned hypertension in the guidelines. Hypertension is far and away the most common problem we see in adults with Turner syndrome. So now we know it's better than 50% overall, since we're looking more closely at it. We have better data. And therefore, it is a problem that we constantly need to look for. Every time you get a visit, you should know what your blood pressure is. And if it does go up, you should be checking it at home. Home blood pressures are very effective. They can diagnose it years ahead. If we're just checking it once a year, what are the odds we're going to be able to diagnose you in a timely fashion? Very low. But if you're checking it at home and you can say, hey, to your doctor, my blood pressures have been running high, can you maybe take a look at this? And that's how we find a lot of our high blood pressures, because our population's very educated. They know to look for that, and they start checking themselves. That is by far and away the most effective. So when you look for, a lot of people ask, what is my risk to have an aortic dissection? We did a study of 425 people with Turner syndrome in the National Registry of Genetically Triggered Aneurysms. So these are patients who were selected specifically because they had an aortic aneurysm, and we followed them to see whether or not they developed a dissection. About 100 of those patients had Turner syndrome. So when we pulled out those Turner syndrome patients and we asked, what are the risk factors that predicted whether someone as an adult will develop an aortic dissection? There were 5, and they're shown here. And the more you had of them, the more likely you were to be on that list of people who dissected. Now, the risk was very low. Overall, it was less than 10% of the group with aneurysms who had a dissection while we were following them for 10 years. However, it went up substantially if you had 3 or more of these. So these are hypertension, a bicuspid valve, coarctation, a dilation with a z-score greater than 3, so a large dilated aorta, and a 45x karyotype. So if you have 3 or more of those, you would be considered in the high-risk subgroup, and we do things a little different for those people. We watch them more frequently, we put them on stronger medications, we may even do special types of imaging for them. So just be aware of that. It's what we look for, in terms of stratifying people by risk. So if you have risk factors, what do? The number one thing is to know the status of your disease and get regular checkups. Know what your aorta is doing. Know what your aortic valve is doing. Get regular images. Control your blood pressure. And again, the top number should be less than 130 and the bottom number less than 80. That's normal tension. If it's higher than that, make sure that you're checking it regularly. And get regular exercise. As Dr. Jones says, exercise by itself is as effective as the leading blood pressure medications to lower blood pressure. So regular aerobic exercise where you're getting your heart rate up is a treatment for high blood pressure. So these are the guideline summaries that I want to hit on again. So regular echocardiogram. We don't recommend getting an MRI until growth has stopped in Turner syndrome because things can change a lot before then. So at least 15 years. Sometimes my adults get it at transition, so that's 17, 18. And then cardiology visits every 5 to 10 years. And if you're planning fertility treatments, which is another thing that people have a lot of questions about, it's very important to assess your aorta before you undergo fertility treatments or cryopreservation, egg harvesting, anything like that, because that can affect your blood pressure. And if you have an aneurysm and you have risk factors for dissection, make sure you know what your treatment options are and make a plan for that, both to prevent dissection, but also if you were to have a dissection, who would you inform? What would your care plan be? Do you have a hospital near you who could take care of you in that situation? And we can often help counsel patients about that when they come in. So here's the take-home points. Know your heart. Were you born with any heart problems? Do you have a large aorta? When do you need to get your next set of images? And should they be an echo or some combination of an echo, CT, and MRI? Well, that depends on where your aorta is and what kind of pictures you're getting. So it's not just enough to get an echo. Was it a good echo? Did they actually see your aorta? Doctor, could they measure my aorta? And if there's no measurement there, that's probably a warning sign that they couldn't see your aorta. And, hey, I need an MRI or CT. I might have an aneurysm. Know your blood pressure. Make sure you're checking it regularly. And if you do have high blood pressure, get a cuff and check it at home. If you're not sure how to do that, I tell people bring it in and we'll measure it right here in clinic for you, and you can practice until you get the same number that we do. If you have high blood pressure, make sure that it's controlled. And one of the things we recommend currently is an ambulatory blood pressure monitor. Now, it's not available in all clinics, but a lot of the high blood pressure clinics do use them. They're very effective to help us change the treatments because we can see how your blood pressure changes after you take your medicines. And sometimes that makes it easier for us to adjust your medication safely for you. And if you're going to have surgery of any kind, whether it's on your aorta or something unrelated to your blood vessels, or you're trying to start a family, make sure you get your aorta checked, because that's a stress that can affect your aorta, and you need to know what the status is before you undertake that. So we have a Turner Syndrome Adult Comprehensive Care Center. It's got an online portal where you can request services. We do same-day visits here, and we serve 5 surrounding states, including, we just get a lot of patients from Oklahoma, New Mexico, Louisiana, but several states farther away than that. And we try to coordinate so that when people are making long trips, they can get everything done either in 1 to 2 days, depending on how many images and visits they need. For example, audiology, cardiology, endocrinology, and then sometimes orthopedics and other subspecialists. We have 10 different subspecialists who work with our clinic. They're familiar with Turner syndrome, and it's kind of a one-stop shop for people who have a lot of needs that need coordinated care. So I'll stop there. Thank you for your attention. I have an announcement. It seems that due to unforeseen reasons, the echocardiograms and the Healthy Heart Project have been canceled for the rest of the day. And I apologize. I don't know anything else. But if you have questions, I would direct them to the Healthy Heart team. All right. And it's time for our next speakers. This is we have 5 minutes? Okay, I didn't have my watch. Okay, so we'll have a brief break and then we'll resume.